Good morning, Chairperson, friends, colleagues, ladies and gentlemen. At the outset, I would like to express my sincere gratitude to Professor Pitul Gupta for inviting me to speak in this symposium. I would also like to express my sincere apology for not being able to be there physically at Batinda due to last-minute domestic compulsion. Coming to subject thrombolysis and what is its current status in 2022. As we all know, ST elevation MI represents the critical phase of acute coronary syndrome. In this entire syndrome of acute coronary event, on one hand, there is a purely a platelet dependent event like unstable angina and non-ST elevation MI. Contrary to that, ST elevation MI is a fibrin rich thrombus which has formed instantaneously and occluded the coronary artery completely, leading to the necrosis. Looking to the pathology of acute myocardial infarction, as the coronary occludes, the necrosis spreads like a wavefront. And if we try to correlate it with the time, in the beginning, within 40 minutes, only the 40 to 45% of the myocardium is irreversibly injured. More than 55% of myocardium is at risk and it can be salvageable. But as the time passes, at 3 hours, only 33% of myocardium is salvageable. And at 6 hours, only 16% of myocardium is salvageable. And therefore, opening the artery and the benefit of reperfusion is time dependent from the first moment of occlusion of the coronary artery. As we can see in this graph, as the time passes beyond 120 minutes, we end up with the larger area of necrosis, large size of myocardial infarct, and that translates into the poor outcome. When we talk about the time to reperfusion in STA segment elevation acute myocardial infarction, the question is, where does the clock start? What we have been talking all these years, the door to balloon time, is it a right matrix? To address this issue, very recently published, it was published in last year only, the time delay, infarct size, and microvascular obstruction after primary PCI for ST elevation MI were correlated with the different time interval, and it was clearly concluded that it is not the door to balloon time, but it is the symptom to balloon time, which is a combination of symptom to the presentation for the primary angioplasty. That is the one which captures the total ischemic time, which correlate better with adverse outcome. It was a meta-analysis of 10 randomized trial, which has shown that longer symptom to balloon time were associated with larger infarct size, greater microvascular obstruction, reduced ejection fraction, and increased death and heart failure. And therefore, as far as the STEMI is concerned, time is very important, time is essence, and choice is rapid perfusion. The aim in ST elevation MI is to open the blocked infarct related artery and re-establish the coronary flow. It should be rapid, it should be early, it should be complete, and it should be sustained. As of now, we have three modes of reperfusion available with us: thrombolysis, primary angioplasty, and pharmacoinvasive strategy. This is graph taken from good old time, almost 25 years ago. As we can see, this is in reference to the thrombolysis. As the door to needle time increases, in-hospital mortality increases. Therefore, as the patient present in the hospital, quicker we reperfuse with the thrombolytic drug, we reduce the door to needle time and therefore we reduce the overall mortality. This was again same time data, more than 50,000 patients of acute MI which were randomized to the thrombolytic therapy or control. As we can see, benefit of thrombolytic therapy was greatest in patients who were treated within few hours of symptom onset. The only drawback with the reperfusion is that some percentage, almost 30 to 40%, do not have myocardial perfusion. Some percent of patients have intermittent patency, and 10 to 13% of patients have a chances of reocclusion. So this issue was addressed when we had primary angioplasty way back in 2000. And in 2003, this was a meta-analysis which was presented by Kile, where the primary angioplasty was compared with intravenous thrombolytic therapy for patients with acute myocardial infarction, and it was a meta-analysis of 23 randomized trial. And as we can see that compared to fibrinolysis, primary PCI offered TIMI-3 flow in a major chunk of patients. There were less chances of reocclusion. There was a better survival benefit, and obviously the risk of intracranial bleed, which was a concern with the thrombolytic therapy, that was obviated. In 2017, with all these 2.5 decades of primary angioplasty being in the scene, if we look at the guideline, 2017 guideline for reperfusion strategy in infarct-related artery, as we can see, in early phase of ST elevation MI, that is within 3 hours, primary PCI and fibrinolytic therapy, they have both class 1A position, and therefore fibrinolysis is still valid if PCI cannot be performed within 120 minutes of from the ST elevation MI diagnosis. And of course, wherever there is facility, primary PCI remains the choice. With the primary PCI, there are multiple barriers: patient-related barrier, social, personal, cultural, financial, insurance barrier, transportation from a far place to the center where there is a facility for primary PCI, hospital barrier, availability of PCI facility 24/7, availability of personals, physicians availability, and of course devices and drugs availability. If we look at the scenario as on today about the primary PCI, majority of hospitals are not PCI enabled. Most of the PCI enabled hospitals do not have in-house interventional cardiologists and paramedics to carry out interventional procedure round the clock. Availability of transport, long transportation time, traffic congestion, and weather condition affects access to PCI enabled center. If we see the capability of the center vis-a-vis intervention, more than 50% of the patient with STMI, even now they present to the non-PCI capable center, and less than optimal outcome is expected in a center which is a low volume center with a less experienced operator. Even the time of the day when the patient presents, patients who present during the off hours after the routine office hours between 6 p.m. to next morning 8 a.m., these patients had a higher rate of PCI failure and 30-day mortality compared to those who presented during the normal duty hours. As we can see here, as the time passes beyond 120, roughly 114 to 120 minutes, the superiority of PCI loses over thrombolysis. These are the data from United States. As we can see, more than 95% of patients treated after 90 minutes. And as the time passes, as the door to balloon time increases, mortality rises steeply. From the National Cardiovascular Registry data, if we see that median transfer time for STMI was 109 minutes, median door to balloon time was 152 minutes. Only 27% of the patients were within less than 120 minutes. If we look at the Indian scenario, it is further poor. In South India, it is almost average patients having pain and presenting to the hospital was 10.8 hours. North India is slightly better, 5.2 hours. It is a large CREATE registry, which I'm sure all of us are aware about it. Look at this CREATE registry. It was more than 20,000 patients who were studied, and 58% of the patients received thrombolytic therapy and only 15% received primary PCI. And the symptom onset to hospitalization was almost 360 minutes. So time delay is no doubt a central in decision-making process. 30 minutes door to balloon, door to needle, and 90 minutes door to balloon time, which is a standard defined for thrombolysis or for primary PCI. These are the extremely difficult goal to achieve. Door to balloon time especially are often much longer in clinical practice than what we have seen in randomized clinical trial. So we have to think out of box. Now we have two bigger innovation in thrombolysis. One is bringing the treatment to the patient, pre-hospital thrombolysis. This has not gained much ground in India, but Western data is full of it. This is way back in 2000, USCI French registry, as we can see, comparing the pre-hospital thrombolysis with the hospital thrombolysis and primary PCI. As we can see in this, that 1 year mortality was just 3.2% with pre-hospital thrombolysis compared to 7.9% with primary PCI and 9% with the hospital-based thrombolysis. CAPTIM trial. This is well talked about study. Here the pre-hospital thrombolysis within the 2 hours is superior to the primary PCI. Same CAPTIM trial, 30 days mortality, cardiogenic shock, 1 year mortality, all were lower when the patient were offered the pre-hospital thrombolysis. Again, this is a French registry data. Pre-hospital thrombolysis has an age over even primary PCI. Another strategy with the thrombolysis is we can have a drip and ship strategy, that is typical pharmaco-invasive strategy. Now, patient present with any location with ST elevation MI, once the diagnosis is confirmed with thrombolize, and once the patient is thrombolized, then patient is shifted to a PCI center within 24 hours. But in case patient present within limit to the PCI capable center, and if everything can be performed within 120 minutes, then yes, it is good to offer primary PCI. Now, pharmaco-invasive approach for reperfusion that offsets the logistic and economic difficulties which are there with the primary angioplasty. We have benefit of pre-hospital thrombolysis, overreaching importance of time to reperfusion, regardless of the strategy that is achieved with the thrombolysis. Thrombolysis alone has serious limitation, and combining the benefit of pharmacological with mechanical strategy of reperfusion that gives a much needed result. And also thrombolysis followed by pharmacoinvasive approach provides clinician with more time to determine the optimal reperfusion strategy, whether the patient can be kept on medical therapy or patient should be offered coronary artery revascularization. Pharmacoinvasive strategy has been applied all around the globe. As we can see data from 2005 onwards, there are several landmark studies, Nordi STMI trial, Transfer MI trial, West Care MI, Capital MI, and Gracia 1 and Prague 1. All these trials, if we look at their pool data, the 30 days composite mortality and reinfarction rate is much less with pharmacoinvasive approach than just primary PCI. Now, last in the study was the STEAM trial, which was published 7 years ago. As we can see the data of STEAM trial, the comparison of 30 days outcome between the pharmacoinvasive and primary PCI, as we can see here, that primary composite endpoint, cardiogenic shock, congestive heart failure, and overall data were in favor of aborted MI that was using the thrombolysis followed by primary PCI compared to those who had a just primary PCI. At 1 year follow-up, as we can see, the mortality in aborted MI was 3.1% compared to non-aborted MI, that is 4.5%. So as on today, if we look at the strategy, what should be our strategy for managing ST elevation MI? Yes, patient with ST elevation MI who present, and there is a possibility of performing PCI within 90 to 120 minutes. Yes, primary PCI is a therapy of choice. But if there is a delay, we should go for thrombolysis. Once thrombolysis is achieved, patient is stable, then watchful waiting can be adopted, and within 24 hours, patient can be transferred to a PCI capable center where diagnostic angiogram can be performed, anatomy can be defined, and a proper revascularization strategy can be planned. Another end of the patient are those who continue to have pain despite thrombolysis. Those who do not achieve reperfusion, they need rescue PCI, so they should be transferred to PCI center immediately. Now, if we look at the data all around the world, this is Canada, pharmacoinvasive strategy versus primary PCI, and they found that pharmacoinvasive strategy scores better. So was the result from the France in the fast MI program. Similar outcome were seen in the Mexico, and this is a data from the India. And here also, as we can see, pharmacoinvasive strategy was as good as primary PCI in STMI in the setting where primary PCI may be delayed or not possible at all due to logistic reasons like financial and other difficulty. If we look at the current global status of thrombolysis in ST elevation MI, still in the major geography of the world, not less than 30 to 40% of the patients are subjected to the not less than 30 to 40% of patients are still receiving fibrinolysis. No doubt in some part of the world the primary PCI rate has improved, but still major geography are using fibrinolysis as a initial treatment of choice in patient with STMI. Similarly, if we look at the median time to primary PCI, in many part of the Southeast Asia and in the Europe, still it is ranging between 5 to 8 hours. In India, almost even now it is 15 to 20 hours. If we see medium time to fibrinolysis, similarly this time is 3 to 5 hours. In India, still this time is 6 to 7 hours. If we see the another part of the world, that is Egyptian registry, even there rate of primary PCI is just 37%. Thrombolysis is being utilized in more than 50% of the patients. Another low to middle income countries like Algeria, Kenya, Libya, Iran, Bangladesh. Bangladesh have almost 81% rate of thrombolysis. Middle East, 29% of the patients still they are receiving fibrinolytic therapy. Russia, 27% receive fibrinolytic therapy. Access registry. This was published in 2011. It was a prospective observational study. 134 cities in 19 countries in Latin America, Middle East, North and South Africa, and they found fibrinolysis is used in 30% of patients and primary PCI in just 26%. If we see the Indian scenario, there was a registry involving 50 cities. Only 58% of the patients with STMI were thrombolized, mostly with streptokinase, and a minority received primary PCI. Besides that, thrombolytic therapy is still a very preferred situation. This is a data coming from the Australia. There are situations when we come across this kind of pattern. You can see the right coronary artery, picture A1. Artery is full of thrombus. We have taken the patient for the primary PCI. Looking to the thrombus, in spite of thrombosuction, you cannot get a clean artery. Instill intracoronary thrombolytic therapy and see the last image, that is image C. You could achieve a better lumen. So thrombolysis is still useful as an intracoronary agent in situation where we take up the patient for primary PCI and artery is full of thrombus, and there one can use intracoronary thrombolytic, and thereafter you get a better lumen, and then artery can be assessed and stented. Now, recently published two major trials, TREAT 2019 and MIDTAS trial 2019. This was primarily a trial involving ticagrelor in patient with ST elevation MI treated with pharmacological thrombolysis. And similarly, in the MIDTAS study, ticagrelor was compared to clopidogrel in patient with STMI. And look at the number of patients in both the study. It means major part of the world are still using thrombolytic therapy as a reperfusion modality in patient with STMI. So ladies and gentlemen, let me repeat. In 2017 guideline, which is being followed till date, and there is no further modification, as far as the reperfusion therapy in ST elevation MI is concerned, fibrinolytic therapy and primary PCI provided both of it can be performed within time frame of 120 minutes. Both the modalities have class 1A indication. As far as the reperfusion is concerned in STM elevation MI, it is amply proved that timely reperfusion is more important than the choice of reperfusion. Similarly, on-site fibrinolytic therapy is better than delayed PCI in interest of the patient. The emphasis on primary PCI as a modality of reperfusion should not obscure the importance of thrombolytic therapy. The critical factor in reducing morbidity and mortality is the time to treatment from the onset of symptom of ST elevation MI. The value proposition of fibrinolytic therapy and pharmacoinvasive strategy we have seen in the recent COVID pandemic. In COVID pandemic, we had dual goals: achieving a timely reperfusion and safety of healthcare provider. Here, the pharmacoinvasive approach came as handy. Patient arrived, we thrombolized the patient if patient was stable. Meanwhile, patient could be assessed for COVID. If the COVID was positive, patient is stable, we continued with the conservative treatment. If patient turned unstable, or if it was a high risk MI, medical personnel safety were taken into account, and then patient was subjected to the intervention. So at this time of pandemic also, pharmacoinvasive strategy is scored over a primary PCI. So ladies and gentlemen, what we have learned till date, that one mode of reperfusion cannot always fit all patients in all locales. When we are choosing the reperfusion strategy, we should have a humanistic and holistic rather than a mechanistic approach. Choice of reperfusion should be based on shoulder of scientific knowledge and also in the evidence which is there from the real world scenario. If we see the journey of reperfusion in STMI, right from the beginning in the early days of 1970, when we had just patient to be admitted in CCU and the bed rest and some antithrombotic in form of unfractionated heparin. When we came to 1986, thrombolysis came into the scenario. It was a mode of reperfusion. 1990, primary PCI was introduced, of course, but thrombolysis remains along with. In major part of the world, both the modalities were going on. In between, intracoronary thrombolysis has always been there, even those days and even now, as I shown in, when there is a artery which is rich in thrombus, intracoronary thrombolysis can be attempted and it salvages. When we move further ahead, by 2000, we have a newer generation of thrombolytic agents which had a better patency rate, which were fibrin selective, but primary PCI and thrombolytic therapy moved side by side. When we reached to 2010, there were mega trials of pharmacoinvasive strategy which found that those logistic difficulty of primary PCI can be overcome by pharmacoinvasive strategy. Again, here thrombolysis remained. If we look at in 2022, there is a primary PCI, there is a pharmacoinvasive therapy, and some cases where we need intracoronary thrombolysis. So thrombolysis was there in the past, it is there in the present, and thrombolysis going to remain in the future. And the current data of pharmacoinvasive therapy, where the thrombolysis is followed by the primary intervention, if it is compared with the primary PCI, pharmacoinvasive strategy in all score stands better. So ladies and gentlemen, thrombolysis is a mode of reperfusion in major part of world, especially in the middle income and poor country. And in fact, thrombolysis is a panacea for poor man with heart attack. Essential component of pharmacoinvasive strategy of reperfusion in developing and developed country, it remains. Mode of reperfusion in developed countries, wherever anticipated delay of PCI is more than 120 minutes, thrombolysis is there. Of course, as I said, intracoronary thrombolysis remains an option in patient with ST elevation MI with large thrombus burden where crossing with wire and aspiration or thrombosuction fail to achieve TME3 flow. We can still instill the intracoronary thrombus and achieve reperfusion. So ladies and gentlemen, if we look at reperfusion in ST elevation in MI in 2022. Thrombolysis is there. It is not dead yet and it cannot be buried alive. Thank you very much.